Okay, it is about 2 minutes past 11:30. We are going to get started. Welcome to the Medication Assistance Treatment Lessons Learned presentation by Mr. Winford Amos. This is the third presentation in the virtual Community Opioid Symposium. This is a free education event brought to you by the Louisiana Department of Health, Office of Behavioral Health, Acadiana Human Service District, and the Women's Foundation. For information on future presentations in this series, please visit womensfoundation.com/COS. This session is accredited for 1.5 hours for LPC, ADRA, AMA, PRA Category 1 credits, and it was submitted for 1.5 social worker CEUs. Full participation is required to receive credit, and after the event, you'll receive an email from the Women's Foundation with detailed instructions on how to claim your credits and access your certificates. Mr. Winford Amos has no financial disclosures, and none of the members of the Symposium's Planning Committee have financial disclosures. A few highlights from Mr. Amos's 16-year career in the behavioral health field. His experience covers mental health, family therapy, vocational rehabilitation, as well as substance use for adolescents and adults. He has been instrumental in the development and implementation of treatment programs within the criminal justice system. He has directed quality improvement and compliance initiatives. And under his leadership, Mr. Amos's team conducted trainings for both private providers and government entities, including Lafayette Consolidated Government. Without further ado, I give you Mr. Winford Amos.
All right, good morning, everybody. Today we're going to do more of an overview during this lunch presentation of looking at medication-assisted treatment with a little bit more of a focus on the clinical aspect. And also, I hope to, in this presentation, give some information for those that are out in the community looking to make referrals into systems of care that are providing medication-assisted treatment or providing supports. Give an idea what is the same as far as with regular referral to addiction services and what might be a little bit different when engaging those systems. And just to touch the structure of the presentation will be a little bit different than what I normally do. We're going to do the presentation, and we're going to have a little bit of time for Q&A, and then there'll be a video at the end. I'm doing this as part of lunch break, and so like you guys are doing lunch and learn, I'm also on a lunch break as well. So I want to be a good steward and be back at 12:30, and then they will facilitate that video. I think you'll appreciate the video. It's a good TED Talk that gives an idea of what a patient or someone that has the challenge of becoming dependent to opioids and what it's like trying to access care. All right, so first we want to look at core of what we're talking about. Talking about medication-assisted treatment. I would say that when we started out in Louisiana, there was a lot more medication-only treatment than medication-assisted treatment. My engagement with medication-assisted treatment was right around the 2012 time when patients were having trouble. They had been getting prescribed buprenorphine. At that time, there wasn't much regulation to make sure they were doing any type of counseling. And as they started doing quality checks, the physicians and those who were prescribing were let known that they had to have some type of proof that people were receiving some type of counseling in order to continue receiving the medications. That led to quite a few people beginning to call my private practice saying, please, if you help me with this, if you don't help me rather, I'll lose access to the medication that's really been helping me. And before then, I had not really engaged with medication-assisted treatment, had been dealing with the impact of the emerging opioid epidemic, but that was when I really started to delve in and to see what could we do to help this particular population. So medication-assisted treatment is medications and counseling. Some of the key things that it does for us is that it can reduce cravings and withdrawal symptoms, and looking at ASAM levels of care and looking at the determinants for levels of care, withdrawal management, cravings management can very much be handled with medications. It blocks the neurological pathways that produce the high and can induce negative reactions when a substance is taken, depending on what type of medications that is being used as part of that process. So we're going to look at a few different areas and start talking about with the different systems, people engage um, the treatment domain in different ways as far as receiving services. You know, years ago, there was an initiative where it was a no wrong door. That way, if a person, no matter what type of agency they walked in, there was an ability to try to get that person connected to services. We're looking at trying to do something similar in this. So when a person is going in the medical domain, like for medication assisted treatment, they are getting the medications, overall general medical care. Within the addiction services, the primary is counseling with medication assist. If you're looking at early intervention, outpatient or intensive outpatient levels of care. Once you get to the inpatient level of care and detox, you begin to have more of medical monitoring or medical management, and medical becomes more of a primary domain. Same thing with medication assisted treatment. Medical becomes primary and counseling becomes an adjunct to that medication. We have still within Louisiana, it's very common for you to enter mental health care as in a way that is not connected with medical services and addiction services. And that may be just for medication by a psychiatrist or a psychiatric nurse practitioner. You may receive pharmacotherapy where you're receiving both medications and counseling, or it could be just to a mental health professional and receiving counseling only. And recovery supports, I think this is really important on some of the things we hope to see coming forward within our state, to where with certain populations, I know if you do the research, and I can tell you just from anecdotal evidence of working with addictions pretty intently for the past 16 years, is that African Americans are more likely to engage the faith community for help before they do other systems of care, whether it be mental health, addiction services, or medical. I've seen that all the way back 20 years ago when I was doing hospice, to where it was such a stigma. There was just not a comfort with that population of engaging hospice services. So I put faith community primary mainly as just as an entry point of where we would hope to see that people could find a way that they could engage, maybe have some screening accomplished, and still from that particular point be referred into the appropriate services that they might need. And there's other ancillary services. When you're looking at it, this is a lens from a counseling perspective and seeing the adjuncts that goes along with us when we're doing counseling. And it may be employment. For example, I do some EAP work. In the past, I was also doing some SAP work, substance abuse professional, to where if individuals tested positive as an accident, if it was Department of Transportation or with a DOT type eval, you have to go through a process. I've received referrals from companies who, from a random drug screen, an employee tests positive and they need an assessment. They need treatment planning, basic return to duty type of a setting. So their primary place they would have entered into receiving services would be through employment. Received quite a bit of referrals through the educational system. When I was working at the Lafayette Parish Sheriff's Office, we had a collaboration to where we did both functional family therapy and Milestones, which was an outpatient mental health and addictions service, where we mainly got referrals from the educational system. And I put parenting, just if you look at thinking of DCFS or other family related services, it's not uncommon from the addiction field that you may get a referral directly from the Department of Children and Family Services or other services in the area, nurse family partnerships. It could be other nonprofits that are doing work. And now we have the OPOCs, the outreach coordinators for addiction, that they may be out in the community and looking to make referrals as well. So the list is not exhaustive, but what happens is that we don't quite know exactly where we're going to come into contact with that person who has an opioid use disorder that may be a good candidate for medication assisted treatment. With some of these systems of care, it's a lot easier for that person to get engaged. With some of the systems of care, it can become a little bit challenging. And some of the challenges, first we had more of a stigma, and I would say that stigma is still there, but it's decreasing. Now, people just don't have the knowledge of where do I refer what do the levels of care look like if I'm comparing the traditional level of care? 15 years ago, if someone came with a pretty moderate to severe opiate use disorder or substance use disorder. Well, we use opiates or benzos for an example. It was pretty standard: detox, treatment, potential halfway house. That was the standard of care. Somebody came with a mild to moderate case, and it was probably going to be IOP with a step down to outpatient, and you have some kind of aftercare or recovery services. So it's really predictive on what the care may be. With dealing with medication-assisted treatment and opioid use disorders, you may not go to a detox because that can be handled at withdrawal management within an office-based opiate treatment center, an OBOT, or an OTP, opioid treatment program, which is what we commonly know as the methadone programs, or it could be just a primary care physician who has a waiver to prescribe buprenorphine. So that whole everybody goes to detox, which would have been a pretty standard approach for someone who was going through severe withdrawal symptoms. That's not the case anymore. So as a general, we're going to talk about screening, talk about referrals, talk about some of the treatment modalities, and take you through some of the tools that are used by the different professionals for screening and treatment and monitoring. So when you make a referral and that client patient may be coming back to you or still receiving services, I want to give you an idea of what that client is experiencing when they are taken into that particular office for medication-assisted treatment. And for the clinicians that are on the call, I also want to go through a couple of the screening tools and the decision making of referring to levels of care, and that way it'll also show you what symptoms to look for, what are some risk factors, and what are protective factors, and I'll kind of break that down as I go through the screening tools. All right, so the main thing is screening, and what we're going to use, what's emerging as pretty much a state standard. It would be SBIRT, screening, brief intervention, and referral to treatment. What I'm noticing as I've worked in the criminal justice settings, I've worked in public health settings. There was a couple of initiatives years ago with the veterans, and now with also with the Louisiana State Opioid Response. SBIRT it's found its way to be a pretty consistent evidence-based practice that's being used. And what I love about SBIRT is that all the different community partners that I mentioned, whether it's the actual medical side, the addiction services, the recovery partners, the churches, the vocational organizations, someone doing financial literacy, if they can all be trained to do SBIRT. You don't have to be a clinician. You're not making a diagnosis. And so it gives us a way to where whatever that safe point of contact for that patient may be, that there's a way that they can receive consistent screening that's universal throughout the state and be able to be referred into services. All right, so what is SBIRT? SBIRT is an basic screening, brief intervention, referral to treatment. You can refer to specialty care for patients with substance use disorders. And one thing I love about it as a public health model using SBIRT is that if a person does not meet criteria that they need formalized addiction services, or if they're screening positive for a, say, a potential major depressive disorder or an anxiety disorder, if they're not screening to a point where it's clinically significant, support in just a safe environment may be all they need. And so you can see people emerging, and if the same screening process is done maybe 6 months down the line when maybe a person is starting to exhibit some symptoms, the screening may be more significant and be positive at that point, where they may need a referral on to more specified services, whether it be for addiction, mental health, or co-occurring treatment. I'm going to kind of skip. And the main thing here is on this particular slide is to know that it's comprehensive, it's integrated, and it's an actual public health approach to delivery and early intervention of treatment services. Again, it can be used for early intervention, and it can be used with someone who has an actual substance use disorder. Primary care centers, hospitals, and other community settings provide excellent opportunities for early intervention with at-risk substance use and for intervention with persons with substance use disorders. All right, so let's talk about some of the screenings in the overall approach to medication-assisted treatment. And this particular information comes from the CDC's website. And the PDMP, or the Prescription Drug Monitoring Program, is a way that, and from a different screening standpoint, a patient is coming into the physician's office, and it could be that they're exhibiting withdrawal symptoms. It could be that they actually report through expert. It could be that they know it's a pattern that they've now been to the same office for the third or fourth time seeking opioids. Being able to use the actual PDMP to see what has been prescribed to this patient within a certain period of time, see if there's any duplicate prescriptions, if they've maybe been getting prescriptions at multiple locations. And also a key thing when you're looking at medication-assisted treatment, you know, has this person also prescribed benzodiazepines, which could put them at a higher risk for overdose because of the respiratory depression that can be caused by both of these substances. So I'm going to put this on the screen where you can see it a little bit better. So we hear about the PMP reports. This comes off of one of the training websites, and it's a sample report. It's nobody's actual data, but it gives you an idea of what the physician and or other health professionals are looking at when they pull that particular report. It does come with an actual score. This is not within my scope of practice, so I'm not going to go into the details of this. I have worked alongside individuals who are using these reports, and we consult based on what is being seen on those reports. The part of the report that was more relevant for me, which was pretty standard, was, here you go, what have they been prescribed by medical professionals, the frequency, the amount, and then you can get an idea from the medical perspective, what is going on, what's the prescribing practices, what type of care has this person been receiving, are there any contraindications for medication. So when you see this is a very good screening tool, similar to SBIRT, where physicians and others that have access to the prescription monitoring reports, so they can see what's going on with the patients. If they see any behavior that may cause concern, this gives them a way to go ahead and engage, see what's going on, what has been happening with this particular person, and make some decisions clinically on what to do. Now, at that point, it may be that they're screened a little bit more specifically for a possible opioid use disorder, or seeing what's going on because they might have been prescribing something for pain but didn't know that the person was actually going to a mental health professional, or going to a psychiatrist or psychiatric nurse practitioner, or someone else that is, or you may be your primary care who's prescribing some benzodiazepines that are being used for maybe some type of severe anxiety disorder. Accidental overdoses are still part of this epidemic that we're dealing with. You can look at a simple thing to where, as a professional, it may seem like just common knowledge to you, but you have someone who is was on benzodiazepines. They may know not to drink with those benzodiazepines, but let's say then they get in an accident, something happens, and then now they prescribed a pretty significant amount of opioids. They consume that with the benzos, and then if they have a kind of, as far as some point as have more of an addictive disorder that's already present, if they drink some alcohol, accidental overdose can happen pretty easily by mixing those three substances together. And so just want to talk about this for a second. Yeah, the PDMPs can alert you to provide potentially life-saving information interventions to take actions to improve safety. Um, it also can give, and you would hope that once seeing these things on the PDMP, that they wouldn't dismiss the patients from care. If the patients are receiving high total opioids, they can consider collaborating with the patient and taper opioids for chronic pain. And again, this is all within the CDC's website for public domain. I just want to give an idea so those are out there practitioners that are collaborating with professionals and they've made those decisions and they're having a discussion with you now. And we are full of acronyms in public health and behavioral health, and now it's kind of just in our culture now. So when they start talking about, well, on the PMP it said this, and you're kind of sitting there like, well, first of all, what does PMP stand for? And I have no idea what it looks like. For those of you who are more visual learners, I wanted to give you something to get an idea, because you may hear about PMP results in a consultation, but not ever see what the report looks like. All right, another, as far as clinical opiate withdrawal scale, is very commonly used within detoxification centers, and it's also used within by the medical professionals within office-based opiate treatment centers, also at the OTPs, which is your methadone clinics. So for those who are maybe non-clinical but still are working out there and outreach, your boots on the ground, engaging people in the community, one thing good about the clinical opiate withdrawal scale, it'll give you a little insight on kind of what are some key symptoms that might be involved when looking at a person with that's suffering with withdrawal from opioid use disorder. So you can have resting pulse rate, of course, that would be something that's monitored by a health professional, sweating, restlessness, pupil size, bone or joint aches, runny nose, or tearing, GI upset, tremors, yawning, anxiety or irritability, and that very common goose flesh skin. All right, now this particular slide, I went into where there was some pretty good research that we can draw off of, and this slide comes from the Clinical Decision Support Tools for Addiction. It's for the California hub and spoke system. We do have a hub and spoke system that is implemented as part of the Louisiana State Opioid Response within the state of Louisiana. This information was in the public domain, and so I was able to pull off of their information in a way to give you an idea. There are similar screenings and monitoring tools being used as part of the Louisiana State Opioid Response. And so we're going to look at two key things. One is the treatment need questionnaire, and also the OBOT Stability Index in Louisiana. They call it the Patient Stability Index. And what I want to do for those who, I commonly get asked questions to where, how would I know? How could I maybe get an idea that what are some things that should prompt me for the person I'm working with home visiting, or the person that's coming to, maybe they're struggling and they're part of DCFS and they're getting some employment training, and you notice that there's some just something that's not there. What are the type of things should I be looking for? And for the clinicians, I'll give you the scoring and kind of give you an understanding of what is being looked at by the questions being asked. That way you can get an idea of what are some of the key things, more the determinants, and we'll look at some of the protective factors that you want to look for as well, because the same way that we're looking at risk factors, it's also very important to look at protective factors. And why that's important is the goal would be is that you want to try to get the client in the least restrictive level of care possible. And being in the least restrictive level of care is more beneficial for the client. For example, there's a detox program now that's at Abbeville General Hospital. I believe it's New Visions. When you go to that detox program, you are actually in a regular hospital room and you're treated as just a regular patient within the hospital, which is different from a traditional kind of locked off and segregated detox unit. But if you can successfully treat a patient at an outpatient level of care with someone that's prescribing the buprenorphine and some good supportive counseling that's happening with other adjunct resources, whether it's within the same outpatient clinic, then that would be beneficial for the patient not to be, say, like in an inpatient treatment center where they're away from their family for, say, 30 days or longer. All right, so the treatment needs questionnaire is, this one is coming from Vermont. Just wanted to quote the source. It was a clinical pathways and payment bundles for medication-assisted treatment from January 2017. All right, so let's look at, go here to the other side. One of the first questions that you're asking the treatment needs questionnaire is, have you ever used a drug intravenously? So IV drug use definitely is something that would be more of a higher risk, because someone that's with IV drug use have also exposure to other public health issues, HIV, hepatitis C, and other health problems that can be related to using IV drugs. So of course that one, if you're going to notice a person who answers yes to that question, they would have a score of 2. And the next question would be, if you've ever been in medication-assisted treatment, oh, sorry about that. If you've ever been on medication-assisted treatment, like whether it be methadone or buprenorphine, were you successful? So what you're looking for is that, when we're looking at evidence-based practices, one thing we want to know is if this has been tried before, if the person has been unsuccessful on that, putting them right back on the exact same regimen without doing further assessment to see what we may need to do to help that person to be more successful. So the previous treatment failure with medication-assisted treatment would show a little bit of a higher risk factor. So we need to try to dig in and see what happened with that failure. And when we say failure, meaning that not that the person failed, sometimes, the approaches or the actual individualized treatment program, individualized treatment plan might not have worked well for that particular client. I've had a situation where patient was doing extremely well, and the community that they were living in, again, there's still some stigma. You can go to certain 12-step recovery meetings that will be accepting of you being on medication-assisted treatment. Certain ones are not. And that person got engaged in a setting, had been doing well. Their drop out of medication-assisted treatment was really connected to them just feeling like they weren't accepted into the group and that they weren't, quote unquote, in recovery. Again, we've made strides, and that doesn't happen as it did, 5 to 7 years ago. But that was a real thing when I first started doing this back in 2012. All right, another thing you want to know, does this person have a chronic pain issue that needs treatment? Because now you're looking at a more complex patient, because this person, now they do need treatment, but again, looking at the whole person, they still have an issue with pain. They have chronic back pain. We have to, acknowledge the fact that some of these individuals who are now in need of medication-assisted treatment didn't go through what we can call a traditional path, as we've seen years ago, of engaging substances. They may be coming into medication-assisted treatment and have never used an illegal drug. This could have been from overprescribing. It could be that the person was in a pain management situation and was receiving a lot of drugs over a longer period of time, and that they had become dependent, but had never taken more than was prescribed. But now they're an issue that they need the medication-assisted treatment because that pain management regimen is not working, and there needs to be a way to taper that person down. So here you have a person who is now dependent, but may not meet other criteria for an opioid use disorder, but the cravings and withdrawal management are a real thing for that particular person. So chronic pain issues are really important. Do you have any significant medical problems, hepatitis, HIV, diabetes? Do you ever use cocaine even occasionally? Why would cocaine use be an indicator, something for you to really be concerned about? If you get a little bit deeper into how people normally pair or how they engage within a lifestyle of using certain drugs, it's not uncommon once a person gets into using drugs that are more from street or illicit drugs. You can do speedballs where you might have both heroin and cocaine or heroin and meth. So seeing if this person is using these other drugs also lets me know a little bit about what's going on. They're not on, they'll say they were getting all of their pain medication and they were getting it through prescription and getting it legally, but they're also engaged in activity where they're buying cocaine and have access to street drugs. This lets me know that if this person, um, you stop prescribing the medication, or if it tapers too quickly, they may turn to just go ahead and get heroin or heroin and fentanyl off the street in order to supplement, because they're already within that lifestyle and have easy access to street drugs. Do you ever use benzodiazepines, even occasionally? Again, it's just a very much of an increased risk with benzodiazepines and opioids being taken together. Do you have a problem with alcohol? Have you ever been told that you have a problem with alcohol, or have you ever gotten a DWI? Again, your same thing in the concerns we have with benzodiazepines. Um, there was a it was a documentary that I was watching. It was some years ago, and this story just really hurt. It stuck with me, and there was this particular guy. He was in college, and he died from an accidental overdose, and his friends and family talked about what happened. He went out to party with some friends who they had started off doing Lortabs, and then from there had gotten into doing Oxycontin or Oxys, and then they had actually moved up to doing Roxy. So he went out with them first time, and he took one pill, which was I think a 30-40 milligram pill, and then he was drinking alcohol. Made it through the night, got home, went to sleep, and never woke up. This person didn't have any kind of history of using substances. He was trying new experiences as far as when he had engaged in college, and that was the tragedy of mixing the alcohol with the opioids. All right, so let's look at a couple more of those. These are, if you notice, their scoring is only one. These are some risk factors, and some we're looking to see if maybe some protective factors are present. Do you have psychiatric problems? Again, major depression, bipolar, severe anxiety, PTSD, schizophrenia. Well, especially if you're looking at that person does have an anxiety disorder, there is a potential that they may be on benzodiazepines. Or you're already currently going to AA or counseling. If they say yes, that's a score of 0. Again, that's a protective factor. If they're not, it's looked at something that is still clinically significant, but not as significant as some of the other risk factors that we were looking at. Looking at motivation, are you motivated for treatment? Do you have a partner that uses drugs or alcohol? Do you have 2 or more close friends or family members who do not use alcohol or drugs? Is your housing stable? Do you have access to reliable transportation? So for those who have been in the addiction treatment field and using the addiction severity index, you'll notice from those particular questions, the TNQ was developed utilizing key questions from the addiction severity index and putting it into a format that was usable as a quick screen to make some clinical decisions to see what might be a good initial referral to level of care for a person that's presenting with a possible opioid use disorder. All right, so total possible points is 26. If the person is scores 0 to 5, they're a good candidate for office-based opiate treatment. If the person scores 6 to 10, they're a good candidate for office-based treatment with a tightly structured program and on-site counseling. If the person scores 11 to 15, they're a good candidate, and the key thing here is candidate for office-based treatment by board-certified addiction physician in a tightly structured program or a hub induction, which would be your methadone clinics, the OTPs, with followed by an office-based provider. So these particular scores are not to be, used at here. This person got the score, and it's definitely what they need. You want to look at risk factors, protective factors. Um, Mostly what happens with this for a clinician, once they start to test positive in this way, maybe they screen positive with an expert for on the PHQ-9 for possible depression, possible anxiety. Have to rule out, is that something that is substance induced? Is it something that predates when they got involved with the as far as using opiates or the opioid use disorder? Is this a person who doesn't really have a history of any type of problems with addiction and is maybe just emerging and is now struggling just to taper off the opiates because they had gotten an accident? So you still need to look at the whole story, consult with everyone who's involved, with the physician. Also, if this person was referred and they came from the community, they came from the faith community, if they came from a home visitor, if they came from an outreach program, they came from an educational program, those programs know that person and can have an idea. This may be that it's a new onset of disease. It might be also some stresses in that person's life to where it may initially seem like, oh yeah, we really need to send them to the highest level of care. Clinical judgment and further assessment will be the thing that should drive what happens next with that particular individual. All right, with the OBOT Stability Index, you begin to see the purpose of the Stability Index is to assist an OBOT treatment provider in determining patient severity and treatment response within an OBOT setting, rather than the status quo of prescribing 1 month supply. And this goes into a lot of detail about just how it can be used within that setting. And my focus today is not really try to in any way give some guidance on a way that it should be handled within a particular office. Again, this is based off of California and Vermont and their system. Louisiana, we have our own systems of care. Our levels of care and severity is a little different, but pretty similar with using ASAM levels of care. But we have to look at what availability and access we have. So one of the reasons I wanted to really talk about the OBOT Stability Index is because when you are monitoring a patient with opioid use disorder that's on medication-assisted treatment, how you are looking at ongoing assessment for stability is a little bit different than if you're working with, say, a person who might have had a stimulant use disorder. And so let's look at a couple of those things right quick. All right, so here we want to know, was the patient's previous drug screen positive for illicit substances? So we know that that's a traditional way that we've done in using urine drug screens as a way to monitor whether a person has been continually uses a substance. So we want to know, was it positive? If the person was positive, or if the patient was recently started on buprenorphine, does the patient have fewer than 4 consecutive drug-free urine drug screens? So again, a person that's still in the earlier phases of treatment, you want to pay a little bit more attention to. You want to look at once a person gets that those 4 negative drug screens, or I mean a drug screen that does not show illicit drugs, that could be over a 4-week period if the person is being seen weekly for drug screens. It could be over a 4-month period if you're doing this stability index on a monthly basis for a person who's a little bit further along and doesn't need quite the intensity and frequency. And so this gives you an idea, and it's just tracking you. How do I know my patient, my client, is becoming more stable? Is the patient using sedative hypnotic drugs, and for example, benzodiazepines or any admitted alcohol use? Again, we want to monitor that because even on buprenorphine, that is still a risk as far as an increased risk to be contraindicated or accidental overdose by a heavy amount of benzodiazepines along with some buprenorphine. Does the patient report drug craving that is difficult to control? And we know from treatment in general that if a person is still experiencing craving, the potential that they may go in a relapse to try to see what they can do because of the discomfort that comes along with cravings and cravings as well as the withdrawal symptoms. You'll see when I play this video for you at the end that the kind of the story from a person who experienced that, it is a tough place. I mean, a person can get to where when they're saying is not only the cravings are difficult to control, they feel such a loss of control. And if there's already some symptoms of depression, that person could be in a really tough spot. All right, does the patient endorse having used any substances in the past month? That's important too. And now we're hoping for a good positive report from the individual because they might have used substances and it didn't show up at a urine drug screen. But, and this is not uncommon. I've had that happen with some of the patients that I've worked with. And it helps you to engage them and modify the treatment plan and intensity in a way that can help to give them what they need. I think of one patient who went from taking buprenorphine orally to an injectable, I think Sublocade, because they were saying that they didn't have the wherewithal, the discipline to take the medication. And when they did have some cravings, they had a tendency, and they did have a relapse at one point where they stopped taking their medication and went out and relapsed on their drug of choice. And for them, the injectable was better for them. And it was based off of a self-report that we were able to get this information. Did the patient report that their last prescription as being lost or stolen? Again, key indicators that if there's a report of lost or stolen, may or may not be the case. We're not here to judge whether that statement is true or not, if they say it's stolen or lost, but we do know that now we're getting into a potential diversion situation. Are they in an unsafe environment and someone did steal that? Do we need to look at maybe possibly referring them to a three-quarter house, an Oxford house, some kind of sober living home to where they can be more stable? Or is it that now they're starting to go to a point when maybe they're diverting their medication? Did the patient run out of medication early from his or her last prescription? So again, potential things we're looking at what's going on in that patient's life, get an idea. Are they taking more than prescribed? Is someone else using their medication? What are the things that are going on? So that would warrant further assessment. And so if none at all, the patient is stable. And so you can see that the goal here is really to track along with the patient with a hope that my goal is to get them to a point of stability. At some point in working with this patient, that I can sit down and do this OBOT stability index with them, and we go through and everything is no. And there shouldn't be a time frame on how long this person is actually receiving these type of services. For some people, we've seen them come to this point in 6 months. I've worked with people that it took them 12 to 18 months before they ever really got to that point of stability. And so it allows you to individualize care, see what's going on, isolate to see where the challenges are for that particular individual, and then you could make clinical decisions and work together as a team. Because remember, it's the prescriber that's involved. It's the actual the clinician that's involved. They might be involved in recovery support services, and they might have been a referral to you from other agencies within the state. It could have been from the criminal justice system, where they were mandated to receive services. And so for them, not being successful or not having a good collaboration can cause that person to maybe have their probation revoked and going back to jail because we just didn't have good collaboration. So as we've seen these systems in the beginning, just kind of to touch on that for a second, that's really something that's going to be important for us, as a community to really embrace. It took me quite a while to understand fully what all is being done in the response to the opioid epidemic in the state of Louisiana, and I'm still learning. There was a criminal justice response and funding that went in that direction, and I had some part as far as was able to be involved in that. There's Louisiana State Opioid Response, which has several different branches, very complicated. You have the Overdose to Action grant that's also within the state of Louisiana, and there's more, even smaller pools of funding through HRSA directly to providers that they're getting funds to help to deal with this. And so it will take a concerted effort from us to work together, first of all, to hopefully have some universal screening, get the the referral process going well together, and just spending some time knowing what it is that the patient needs for them to be successful. All right, so these last couple of slides, I just want to talk about um, system as we know it, and if I can, all right, so system as we know it. If a person is being prescribed an actual, say we use buprenorphine, it could be Vivitrol, they could be on an injectable naltrexone. They may be an intensive outpatient program. They may be receiving those particular medications from a prescriber. But again, they're outside of that traditional system, and they're receiving outpatient services at either an individual therapist, or they could be receiving services from a step down level of care within that was an intensive outpatient program, or they could be just engaging a positive support system, aftercare, relapse prevention. So what I'm going to talk about on this next slide is extremely important when you're looking to make referrals and building your network of referrals. There's different treatment philosophies, and also you have to look at, when you're looking at these treatment philosophies, who's the prescriber that can stay with that patient for a while. I'm going to tell you a couple of stories of what I found out in the past couple of years, and it was difficult in the beginning. It's become, and I'm just grateful that we have the LeSource program, because now, I mean, I know they're pretty close to being right at full capacity of 50 OBOTs active in the state of Louisiana, and with LeSource 2, that will increase even further. It was difficult trying to find a place that you could refer a patient a couple of years ago to receive these services. But even with these services available, let's say a person is going to inpatient and they're prescribed by the treatment center. I'm going to use Vivitrol as an example. When I did kind of survey the community, I was building just kind of a referral base and seeing where I can to send patients. And it wasn't uncommon to where a person might be prescribed the Vivitrol while in an inpatient center. But what is very important to note, that medical director, that prescriber within that inpatient center, at the point of discharge for that patient, they're not going to follow them ongoing beyond the inpatient stay. So now this person, when they leave the inpatient unit, has to now be transferred to either primary care or an OBOT that would take them on to prescribe that particular medication long term. So that's important. There are some programs now that are developing within their treatment levels of care, where there is a prescriber that's there, and there's levels from inpatient to IOP to outpatient, or even if they're within that system of care, that one particular company, they can receive their medications without disruption or without having to start over. My concern, and it's always going to be from the patient's point of view, I've gone to inpatient, I've gone through these things, I've established relationships. I was already using drugs, maybe an IV drug user, got comfortable with someone giving me the injection, and then upon discharge, I have to go now get introduced to a new provider, and that can be hard for them to do so. Intensive outpatient, same thing, it could be prescribed by the treatment center. Many intensive outpatient programs will not do any prescribing, so it's probably going to be prescribed by an OBOT or private place, a pain management clinic, and or the primary care physician. And then for outpatient setting, wouldn't be uncommon to be prescribed by the OBOT or the primary care, and then receiving services from just an individual counselor and or some type of aftercare groups, and receiving 12-step support and other positive support systems within the community. So here I want to kind of look at with the good things that Louisiana has done and what we have available in our systems now. With an OBOT, what's nice, that person, if that's the prescriber, and let's say the person even had a relapse, they could stay with that individual from start to finish. Once they prescribe them that medication, they can go to varying levels of care, but then still continue receiving their medication from one prescriber. Now with that, one piece that it's important is part of the LeSource program, where there's a licensed mental health professional and a nurse that are there to help to monitor the patient and work between the different levels of care. If you're a private provider and you're referring to an OBOT and they're they're your patient. It will be important to really pay attention to the case management function so you can help that individual get access to the other services that they need to be successful. And that way you can maybe become a hub for them, as an individual counselor, as well as the OBOT. And then they always have a good, safe place to return to. So thinking about when you're referring to an inpatient unit, be important to know, will the prescriber continue to prescribe medication after discharge from the inpatient unit? If not, who do they commonly refer to upon discharge? And you want to look at for your client, will they actually take the insurance, and how do we make sure that the person can have some continuity of care? Most patients won't, with medication-assisted treatment, won't be going to inpatient, like I said, most, but we have to talk about Vivitrol and other just kind of a broad spectrum, not just buprenorphine or methadone as opportunity. So if we're looking at something like Vivitrol, it would be very common to go through a detox and an inpatient, but it's still who's going to follow them afterwards. If they're in an intensive outpatient program, will the person receive medication if not compliant with IOP, meaning that will my ability to receive my prescription also be tied to my compliance in the intensive outpatient program? That's important to note because I may not be fully engaged yet, but still totally need that medication to deal with withdrawal and cravings management, not fully engaged in IOP. If I get cut off from medication and counseling all at the same time, that puts the patient at a pretty extreme risk. Will the prescriber continue to prescribe upon discharge if they're in an IOP? Well, then the goal would be then if they're leaving out of that IOP, make sure that there's a step down or a transition to a prescriber that's outside of that level of care. That way that person can continue to have access to their medication. Do they offer outpatient without completing IOP first? I put that on there because it's becoming more common, but often we look at places in the addiction services that offer step-down programs. If you want to get to outpatient, you're going to go to intensive outpatient, then outpatient. With Medicaid and some payers, that's not really allowed because of reimbursement. So we're starting to see a lot more availability of a person be able to just get outpatient services. All right, OBOTs, private pay, LeSore, there's still people that are out there that are going to these places that they are private pay, and they're paying pretty significant to get their medication. Does the OBOT have counseling services available at the agency? If not, where does the patient receive counseling services? Is there a collaboration between the prescriber and the counselor to make sure that there's a good working coordination for the best outcome for that patient? Does the prescriber and counselor have access to PDMP report, EDS results, assessment, and treatment results? And notice, interdisciplinary approach. It's really important to have that relationship to where the prescriber, the counselor, the nurse, everybody who's a part of that care team can know what's going on with these different pieces so they can know how to best support the patient. Does the patient receive regular mental health screenings? Which you'll see when you watch this video that's going to play after this is over. This person went through some severe depression and became suicidal. It definitely had some suicidal thoughts at one point. So though a person may not present that way when they first engage, that doesn't mean that 2 months down the line, 3 months after some post-acute withdrawal symptoms, that they might not start to exhibit those symptoms. Is the mental health treatment integrated with the medication-assisted treatment services? And I'm always going to be biased towards a whole person if they can receive all of their care within one coordinated system. When you start looking at individuals with substance use disorders, especially with the female population, the prevalence is somewhere between upper 60s is the lowest I've seen to 70%, close to 80% have a history of trauma. And so having a person trying to go and engage 4 different silos to receive a coordinated care is just not good for trauma-informed care. So the more integrated the treatment, the better outcome for the patient. And so these are basically some references. I have a few minutes before I have to be on this next training, and I'll be receiving training in about another 5 to 10 minutes. But if there's any questions, you guys can put them in the chat, and I'll be happy to answer them for you. Okay, so this is kind of more of a comment than And then the question, but I will kind of speak to that a little bit, you know, and the way the comment is that my experience is that there is no support from private providers. Can you discuss the step down programs again? All right. So when we look at, as we're going through a change and trying to engage patients on a more effective level of care, there's always a change within the system. It doesn't happen quick. And so traditional, the way that most services are set up with addiction services, they have intensive outpatient level of care, which is normally 9 hours minimum per week of services. They tend to go to that service for 3 to 4 times per week. And then once they have, it's usually about a 6 to 8 week period, they've shown that they've been able to stop, you know, discontinue use, stabilize. They may then be referred down to outpatient, which is a less intense level of care, which is generally somewhere between 1 to 8 hours worth of services per week for that individual. Outpatient would encompass to where somebody maybe went from going to group 3 to 4 times a week to maybe twice a week and doing 2 hour or 4 hours worth of group. And maybe they've even stepped down and they're finished outpatient and they're only doing just individual counseling, and to where they have a continued continued care to deal with relapse prevention, and also those other issues that normally pop up once a person gets to a stable phase within their in dealing with their opioid use disorder. All right, so to be a good steward here, I do thank you guys for allowing me to spend my lunch with you and share some of just my experience, and also hopefully this information can kind of demystify some of the things. I know it was tough for me not knowing what the PMP report was like, not understanding that when I made that referral, what was happening when they were getting the medication assisted treatment, how were they being handled within the clinic, and so this hopefully will give you some insight into that. So I'm going to cue up the video here now, and I hope you enjoy this.